Hi everyone, and welcome back to another live Q&A session with the Star. I'm your host Joshua Lim, and today's topic is about how to stay safe during the COVID-19 transition phase. Joining me today, let me just invite him. Joining me today to provide us with a better understanding on the matter is Dr. Sanjay Rampal, a professor of epidemiology and public health at University of Malaya's Faculty of Medicine. Dr. Sanjay, welcome to the live session. How are you doing today?
Hi, Joshua. Good evening. Thank you for having me. Always a pleasure to come and talk to you about stuff.
Yes, pleasure to have you with us again. And let's just jump right into it. Let's just put up why we're here and the discussions that we're going to have today. Our day to day life has had several challenges and disruptions due to COVID-19 in the past 2 years. And now it seems like we're getting a sense of pre COVID-19 normalcy thanks to vaccines and booster shots and just this general compliance to SOPs. But I guess, with all this normalcy that's happening, there is some uncertainty, there is some unease. We've been through this road before where things open and then after that there's a close. So we're wondering, like, where does it go from here? And Dr. Sanjay, I wanted to ask, do you think that the worst of the COVID-19 pandemic, as we're doing this transition phase, is already behind us?
Thanks, Joshua. With regards to the current wave that we're facing, this Omicron wave, I think the worst is behind us. So we had the highest peak of transmission sometime in early part of March, and since then the transmission has been reducing. The transmission started, I think, in earnest in January, and there was a big spike. But following March and the recent trends that we have seen is there's been a constant decrease in the number of new cases, which is in keeping with general trends we see globally that happen from country to country. So I think with regards to our current Omicron wave, the worst is past us. And I think because of the number of cases, number of people who have been infected by the Omicron wave, we should have some sort of population immunity for a slightly longer period of time. And it will be sometime before the next wave. Now, all that said and done, this is a marathon, right? We do not know what is going to happen in the future, but we think that we are moving to a period of normalcy. And based on the indicators that we have, based on variants that have developed globally, I don't see any big changes happening in the coming months. So I think we will resume towards normalcy for a period of time.
I see.
How long? I'm not sure.
Right. I was kind of going to towards that direction as well. With that said as well, what I'm hearing, was to your understanding, we've hit the peak, the worst behind us. Is there a
One point to note,
possibility?
Joshua,
Yep.
sorry,
Yep.
is
Sure.
typically we look at trends that happens globally, and then we kind of generalize it or extrapolate it and try to predict when the next wave will happen. Currently, we don't see any major variants that will change the trajectory of the disease, and that's why I say it appears to be smooth sailing. Not that we won't have any large waves, but for quite a period of time, we should be okay. Sorry to interject.
Oh, no worries. This is a discussion after all. And for the viewers, if any of you have any questions regarding kind of where we are at the COVID situation right now, you can always put them in the comments, and then we'll try to answer them during the viewers Q&A session with Dr. Sanjay giving his opinion as an epidemiologist. So with that said, with the trends, with the trends that you said showing a more optimistic direction, and you brought up the topic of variants. So what are your thoughts on recent news on the Omicron XE variant and subvariant, and also on future variants? Do they pose any danger? Are they a cause of concern?
So I'd like to answer that in two parts. One is with Omicron XE. So I think with Omicron XE is a big concern for countries which have not had a large Omicron wave, right? So countries, for example, such as China or other countries, maybe India, which hasn't had a large wave in some time, whereas in Malaysia we've already underwent, right, an Omicron wave. So I think there will be cross immunity between these two variants that will prefer sufficient cross level immunity at a population level to attenuate its effects. I'm not saying that it's not going to have a big effect, but what I'm saying is because many of Malaysians who have gotten infected during the Omicron wave, I think it's very unlikely for them to get infected again with the Omicron XE in the next months, in the coming months. Now, coming to other variants of contrast, of concern, or variants of interest, I think that's an interesting one, right? Uh, Mutations that produce variants occur randomly. However, there are selection process that goes in to determine which strains get circulated. So it is more likely that the strain that gets circulated, the next big strain that gets circulated, will be one which is not as severe as what we have seen in the past. It's more likely to be less severe. Now, I'm not saying there's zero probability that it will be a very severe variant, but I'm saying that there's high likelihood they will not be as severe as the previous variants. But it will be infectious, and this points towards a point where we can treat COVID more like a recurring seasonal infection, where you may have outbreaks, let's say in the winter or in the summer, in certain seasonal months. But generally, I don't see it overwhelming our healthcare system like the concerns we had with the wild variant, the first variant, or with the Delta variant. Now, because the Delta variant was very much more severe, the burden on our healthcare system was a lot more. Now, if you notice with Omicron, even though the numbers are very high, and the numbers were high, according to our estimations, we were having as many as about 100,000 cases a day. But when you go out there and you check and you look at healthcare utilization, our healthcare system was not burdened. Now, with regards to our district health system, with regards to the public health system, I think the use of MySejahtera with regards to notification and to the issuance of digital health HSOs helped a lot in alleviating their burden. But we didn't see that overwhelming of hospitals like we did with the Delta variant. And so moving forward, what I think will happen is we may have periods where people will get sick, where there will be a high number of cases, all right? But I don't see our healthcare system being threatened as it was. That said and being done, I think we do need continuous surveillance, right? So I am for random sampling of genotyping the virus and basically surveilling the virus over time.
I see. Now, with these discussions, with the point that you brought up just now, where it's going to be something that has recurring waves, but not as lethal or severe as it was before. The government has recently also announced that the elderly and those who are immunocompromised, especially in the elderly group, would be able to get a fourth booster shot. I'm curious to know your thoughts on not a fourth booster, a second booster shot, which means a fourth administration of the vaccine. I'm curious to know your thoughts on the second booster shot, as I think there are people with questions. Should I get it? Is it something that I need to consider?
So with regards to the second booster shot, I think in summary, the evidence is indefinite, right? We don't have definite evidence stating for a second booster shot at this point of time. What we do have is we do have companies which have submitted to the FDA for a second booster shot, right? And they have been approved for second booster shot. The second booster shot was basically for 6 months following your first booster, following your last shot. That there is some actually very active discussion in the scientific community on a couple of things. Number one, what is the period of interval between your last shot and the next shot, right? So this issue of 6 months, is 6 months too short a period? Should we make it an annual shot, for example? So that is something that is still being actively discussed, and the science is still out there. And I think the more concerning thing is with regards that we are boosting with the same vaccine strain, right? I think that to me is a bigger area of concern. It's like we have been boosting, we have been giving the shots with the same strain now 3 or 4 times, when evidence have already shown, right, that the, let's say for example Pfizer or Sinovac or whichever one of the strains, right, their efficacy, including the booster, their efficacy in preventing transmission of Omicron was only about 30 to 40%, right? They do work for severe disease, so they're about 50%, but I don't see what you get by boosting so in such a very short period, right? So I think it is one where we have to get further evidence. One where I think a booster should be an updated variant rather than the original strain. It should contain all the strains that we know of, right, and that are commonly circulating. That would be more beneficial. Uh, the third thing to think about is vaccine equity, right? We have large proportions of the global population who do not have access to vaccine. And interestingly, we have called this a first world problem, right? Where many countries many Western countries or whoever, first world countries, what they have done is they've stockpiled vaccines and they've been using it for themselves rather than sharing it out.
Mm-hmm.
And we come then to our country, which we are a LMIC country, we are lower middle income country, but with regards to vaccines, we have done very well. So I wonder whether we should be thinking about vaccine equity. Remember that the benefits of vaccine diminishes. That there's a diminishing effect to vaccination. So whoever got the first 2 doses of, let's say, a 2-dose vaccine, they had the biggest benefit, right? You have a large decrease in risk, but subsequent boosters reduce the risk incrementally, and the increments become smaller and smaller with subsequent boosting. So again, if you think about vaccine equity, if you think about global, and one issue with vaccine equity is the next major strain to circulate will not arise, very unlikely to arise from Malaysia. It's more likely to arise from the large populations out there which are unvaccinated. Think Africa, think South Asia, think other populations where there's large proportions of unvaccinated people, where when the infection spreads, it will spread fast, and because so many people are getting infected, you'll get mutations coming up. So there's
So what
three
I'm,
things, three
yeah.
three issues I would think about when you talk about booster. Number one, using the same strain to me is not so useful. We should use an updated strain. Number two, the period between the last vaccine jab and your next dose, I think, should be 1 year. 6 months that there is a lot of evidence also that talk about overboosting. So I think the ideal period for the booster jab needs further thought or further science. And the third part is vaccine equity. Now, all said and done, though, the government's recommendation that the elderly and immunocompromised get a fourth jab or a second booster, what I would tell you is, you as those who are seeing this, if you're elderly, if you're older, right, if you're 60 plus, if you're 70 plus, assess your risk. You are at higher risk of severe disease, right? So the benefit you get from these vaccinations are actually a lot higher than a younger person. So I think for each of us, we should assess our risk. If you're elderly, if you're immunocompromised, the benefits are higher in getting vaccinated in general compared with the general population. But if you're in the general population, I would wait for the science to be more definite.
Right. And then this topic about risk, I want to touch a bit about the risk, because you talk about there are kind of studies or some information out there about the risk of overboosting. I think this is a two-part question. So is it unusual that we have taken up to 3 and even the possibility of fourth booster in just probably less than 2 years? And also, what are risks you that you
Okay,
mentioned? Yeah.
maybe what we should be doing is when we assess whether vaccination works or not, right? So there are many types of immunity. So one thing that has been commonly done is we look at antibodies, right? So when the antibodies decrease, then we say the the vaccine's effect has gone, right? And so that the when antibodies are actively circulating in our body, it helps us against infection. That means if we get exposed to the virus in large doses, because we have circulating antibodies, they will neutralize the virus quite fast. So it prevents you from developing the infection. However, when the antibodies reduce, we still have long-term immunity. But what happens is the virus, let's say, gets in the nose, right? And the virus, or in the lungs, the virus starts multiplying. The body detects the virus. Then the body will react to the virus. So what that does is that means that the immunity we have does not prevent us from getting infection, but the immunity in us helps react and fight the virus and prevent severe infection. Hope
Right.
that helps.
Right. But then what are the risk of overboosting, as we're looking at, like, now the fourth shot, second booster shot?
So I would still say the science is out there, right? So the issue with overboosting is, does it decrease our levels of immunity? I think that's the concern. But with regards to the evidence, because very few countries have used the second booster, right? So Israel is a very good example of where they published some data. Even though they published data it's interesting, but they have published some data. The US has started this recommendation a couple of weeks ago, right? So we don't have much information from them, but I think the science is developing. We will learn more in the coming months.
Mm-hmm.
But the concern is that if you give too many boosters, you can you decrease the body. You may influence the body's ability to produce its own immunity.
I see. And the overall,
Yeah.
but then when it comes to the 60-year-olds and above, and and especially those who are immunocompromised, what you're suggesting is a risk assessment.
So
Yeah.
let's say I'm 60 years old. I am fit as a fiddle. I don't have diabetes. I don't have hypertension. I don't have heart disease. I don't have cancer. I'm just fit, right? Not only fit, I'm physically active. I communicate. I move around, and I'm fit. A, that 60-year-old is very different from a 60-year-old who has diabetes, heart disease, or another 60-year-old with cancer. So the age is a factor, but it's not the only factor. So along with age, I think this term called multi-morbidity is very important, whereby someone with multiple conditions, right? Because they have multiple conditions, these conditions can affect the immunity. Because it can affect the immunity, they're more susceptible to severe disease. That said and done, that is why so this is what we have this is what that has been identified as high risk populations. And the immunocompromised, because they're immunocompromised, there's concerns that even the normal dose, the normal 2-dose vaccine may not have the same effect in an immunocompromised individual compared with a normal individual. So that's why immunocompromised individuals, that's where you can see a benefit for the immunocompromised individuals. You can see a benefit for older, multi-morbid individuals, and that's what I would summarize it as.
Okay. I want to come back to, kind of our first question about the trajectory of COVID-19, and at the state of where we are now. What can we as citizens do to ensure a more safe environment as we transition to the endemic phase?
So I think the main thing about COVID-19 is that we have learned a lot more about the virus, right? So we have learned a lot more about the virus. So we have learned that the virus is infectious. We have learned that a lot of transmission has been airborne, right? A lot of the transmission has been airborne. And we have learned that these variants of virus that are circulating are not as severe as previously, as the previous variants, right? So when we talk about safe, I would say safe is a very it's black and white. There's never black and white, right? So there's never like safe and unsafe. It's safer. So What I would do is I would risk assess the situation. So the trajectory of disease is downwards. We are now at about, I would say, 30%, 30 to 30 plus percent of the peak, which means it's gone down tremendously, right? It's gone down about 3-4 folds. So when you look at the trajectory coming down, right? And one more very important point about risk assessment is that population immunity, I think, has built up tremendously over the past months, right? So whereas previously, when you talk about 1 year ago, population immunity was nil. Now what we have is we have acquired immunity and we have population immunity, right? And also that all those people who have been infected during the Omicron wave are unlikely to get infected for the coming months. So I think with all of this in mind, we can actually look to relaxing many of the restrictions that we have. And I think it's also an opportune time to actually assess, right? Assess how effective many of the things we do, right? So in spite of the recovery plan saying that we streamline our SOPs, there's still so many SOPs. There's over 180 SOPs circulating, right? Each at phase 4. So I think we have to acknowledge the fact that we are past a very big wave. We have to acknowledge the fact that we are going down. We have to acknowledge the fact that the population is fatigued, right? You all are fatigued of COVID. Not only you all, your finances are fatigued of COVID. The nation's finances is fatigued of COVID. So I think what has happened over the past 2 years is we have spent a lot of money, because we are the government. We are the people. So the government has spent a lot of money in the prevention and control of COVID, I think, which was very good. It saved lives. But moving forward, I think it may be time to look at the cost effectiveness of interventions and be more selective in any interventions that we want, right? And being very clear with what is possible and what is not possible.
With that said, do you think we're coming about when you're talking about relaxations? Do you think that a mask mandate is still necessary, as this has been the topic of debate, and it has been like discussed in several other countries as well?
Yep. So I think it's time to remove the mask mandate, and I have to be very clear with how I phrase my statement, right? So I think general masking, it's time to remove the general masking mandate. I think not mask, but medical grade mask and high filtration mask still have a role in healthcare facilities in specific areas where risk of transmission is higher, right? For example, the operation theater, the infectious disease ward, maybe even the outpatient, so on and so forth. But talking about general masking, I think from what we have learned, that number one, it's airborne, so that many of the masks we use are not useful, right? So if the transmission was truly airborne, we would need N95 mask or higher. Proper fitting N95 mask, not just wearing. I've seen many people wear an N95 mask, right? And it's loose and air goes in through the side and all over the place. If you really want the N95 mask to be working, it has to be properly fitting, and then you feel like Darth Vader when you breathe. You're like, right? Because it's difficult to breathe, but that's because the filtration is working. Now, the problem with N95 masks and many of these high filtration masks is they were never meant to be used for prolonged periods. So you can think of this, that if you were to use an N95 mask at workplace for about 8 hours, I think you would have fainted, or you would have gotten shortness of breath, but just by using that mask properly. So what many of us do is we use non-medical grade mask, which had a role when we thought that transmission was droplet based. So the difference is, in droplet based, you can think of my spit coming out, you can think of my any of my nasal fluid coming out, right? You can think of my eyes, and we thought that was the major driver of transmission. So wearing a mask kept the droplets in my mouth, and then that prevented transmission. But now, because with newer information, with more evidence that it's airborne, uh, then there's no role for mask. Uh, the effectiveness of general masking is very low because of low compliance. We must also think of cost, right? Cost not as money, but environmental cost. There is a huge environmental cost to masking because many of us buy the disposable mask. We use once, we throw it away, and we don't care. We don't care where the mask goes. Actually, now, for the past 1 year, many people have used many masks and not worried where it went, but it has to go somewhere. The plastic has been accumulating somewhere, right? So I think we have to think about environmental costs. We have to think about financial costs, right? That the whole nation is actually masking when we need not have to anymore. I do say this for now. In the future, if there's a future variant, or if the situation changes, then my recommendation would change. But for now, for the near future that I can see, I don't see a masking mandate.
But it sounds a bit counterintuitive, and I think because psychologically we have been doing this and we've been told time and again that wear a mask, it helps. uh is there no benefit at all in the whole general masking in this
Oh,
period of time? Yeah.
I would think there was a benefit. The benefit was very, very small. So the point about, I'm talking about non-medical grade mask. I'm talking about, actually, you can think about non-N95 mask, right? I'm talking about the surgical mask, the fabric mask, so on and so forth. So for many of these masks, I think the effectiveness of it against airborne transmission is low. In addition to that, many of us, the way we have been, uh, long-term use of mask had always been difficult. And the idea that you use a mask and then whenever you take it out, you hold it, you deal with it, I think the overall effectiveness would be very low. Now the issue is we don't have real world evidence. We do have modeling evidence, but the problem in modeling is assumptions. So I'm still looking out for real world evidence on masking, and that's why there's been many nations that have sidestepped the masking mandate, right? Now, all said and done, there are different periods to this 2 year pandemic. What I would be saying is I would be very comfortable in periods where I think the transmission is not high, the transmission is low. I would be very comfortable with not having a general masking mandate. I think a general masking mandate would be like a last resort when transmission is very high, um, and you would want to do something.
I guess it is kind of a nuance and layered kind of like a issue as well, right? You can't just say, yeah. Like you presented, it's the environmental cost, it's the overall effectiveness during the exact period that we're discussing as well, and not just a one thing like, oh, we shouldn't just wear a mask in general, and
Joshua,
what
you know
kind of
why
mask as well.
why I was smiling?
Yeah.
Because I had this discussion with a friend of mine, right? And he was like, "Tell me in simple words, mask, yes or no?" Right? And then I gave him this discussion and said, I don't want to listen. I just want to listen to yes or no, right? And I think that's the problem with messaging in social media and many of the messaging. Simple messages get across the masses, right? But simple messages do not convey the full amount of information we have, and that our decisions may change from time to time. I think that's one key word that I've used over, which I term it as calibration calibration of our NPIs, of our interventions based on transmission dynamics. So meaning, in a certain period we may say use mass, right? Now, the message of use mass, in propagating the message, there might have been an element of fear being used, and I think at that point of time people thought that was the best way of propagating the behavior change. But I would say that as periods change, knowledge change, and the virus, the human, everything changes, and because of that, our decisions should not be static over time. Our decisions should be updated on the amount of information we have.
Yep. Thank you for putting it into perspective and proper perspective for people to consider as well. While we're on this topic, in terms of like relaxations and things that we have that may have to be recalibrated, curious to know, what about MySejahtera? What are your, do we,
Yeah,
some groups have called for a review? What are your thoughts on it?
that's actually a very good question, and I think it's been in the news around. So I would divide the users of MySejahtera into number one, location scanning, and number two, other medical users. So with regards to other medical users, we have used MySejahtera in this past few months for notifying our status. Whenever any of us are positive, we notify our status. And I think MySejahtera was a good app in helping us self-notify. MySejahtera also issued digital HSO, which then gave us a digital certificate stating that we should stay at home. I think this activity alleviated a lot of burden from the district health office and the public health system. So MySejahtera worked that in that aspect. Now coming to location tracking, I think that the QR codes, it's long overdue that we remove QR code scanning, right? QR code scanning was a short-term solution in this pandemic, and I think has outstayed its welcome. Rather, the evolution of location tracking has gone to Bluetooth, and I think MySejahtera has the capability with MySejahtera Trace. However, we must acknowledge that there are trust issues. We would all want a very transparent. We want transparency with regards to who holds our data and why, what they can do with our data. But with regards to location tracking, I think it's time to do away with QR code scanning, because overall, I don't think so. It had helped us in solving many of the outbreaks.
Mm-hmm. And do you think that, what do you think that physical distancing as well, that is that something that still stays in place, or we require a review? I think we're just going down to the things that we've been
Yeah.
told over the
Okay.
years. This
So
is
so
this is what
this,
we
so
need to do.
this
Yeah.
is so as I said, recalibration, right?
Yeah.
One of the only NPIs which have been very effective is physical distancing, I think. Right? If you
Mm-hmm.
think about physical distance, what does physical distancing do? Is that it increases density of people, density of population. The intention is brilliant. When done properly, it has brilliant effects. Here's the difficulty. How do you decrease population density in KL without changing the environment of KL?
Mm-hmm.
So we had this issue, right? So what we said was, okay, remote working. Everybody work from home. By working from home, we decrease people coming into KL, right? So that decreases density. What else can we do? 1 meter distancing. And then you go to the LRT, and how do you practice distancing when we don't have the facilities to facilitate the distancing? So my point again, in short periods of time, I think it was a good intervention, but for the longer term, without changing our built environment, without changing our environment, I think it's very, very difficult. Easy to talk, right? Very easy to recommend, but implementing it properly, very difficult. Think of your simple point. Think of your elevators, right? If you have a busy building with, let's say, 2 elevators, typically the elevator says 15 people, right? Now we say, oh, wait a minute, physical distancing, 5 people.
Yep.
Easy instruction. But then what happens is, are you willing to wait 15 minutes for the elevator? If you are, then okay, right? But 15 minutes for the elevator, going to the MRT station, you got to wait 1 hour just because to properly distance people. So what I think we have done is, we have used it as a recommendation, right? But I'm not sure about its implementation. So rather than being hypocritical, I think now maybe a good period to recommend it, but not enforce it. Because I think enforcement is an issue. Because without changing the environment, how can we enforce recommendations like this, guidelines like this? So keep it as a recommendation. It's good to keep recommendations. but life's going back to normal, right? All school children are going back, all workers have to go back to work, right? Put it this way: if a workplace has the flexibility to practice physical distancing, by all means go ahead. But if it's difficult, then I think the problem is, do we have the resources to invest in our built environment to make our areas less dense? And I think this is a very difficult question if you think about it, especially in urban areas, which make up 70% of the population, where 70% of the population resides in.
Right, especially when we're going to festive seasons, we're going to observe more
Yeah.
situations with intent with a loaded or crowded areas and stuff like that.
So
And I
I
think,
think,
yeah,
yeah, please continue.
yeah, I hit it on the nail there because, and I get that is the challenge of the transition period and why we're here discussing this today, because we feel that things are getting better towards normalcy, but that the rules are still in place, which kind of still gives us a resemblance of uh, the old SOP, like when COVID was at its peak as well. So like transition also means this kind of difficulty between picking where are we really and what kind of SOPs that need really calibration and what do we need to maintain during this period as well, so that we can move forward in the right direction. Yeah.
Joshua, I think you bring up a few important points, right? One important point about recommendations is, I think we have to acknowledge that many of our recommendations get influenced by the political processes, right? And somehow opinion matters for political processes. So that's why sometimes we get this Jekyll and Hyde kind of reaction, where there is a move one day, right, saying certain policies, then there is some statements in the media, and there's some feedback from media or certain parties, and then it goes back the other side. It's flip flop, right? And I think this is where we also see that some places talk about enforcing SOP, some places are relaxed in SOP enforcement. I think that brings up a lot of ambiguity. That actually decreases trust in the system. And the issue about trust in the system is when SOPs are unevenly enforced, right? It it results in severe trust deficit, which affects our ability to influence the population to adopt better behaviors.
Mm-hmm.
But my sorry, one of my points there was political processes sometimes influences many of these flip-flop policies.
Mm-hmm. Which then erodes or causes more confusion, and just kind of just degrades the main intention for how something that serves the greater good here. Uh, I'm curious to know, just as an extra thought here, on the policies that have been going on surrounding quarantine. And I think, recently it may come to a shock to some people that even individuals who have not been fully vaccinated, who are close contacts, are able to, or do not have to quarantine, do not have to be in quarantine. And we've seen a lot of relaxations in this area, which may cause some discomfort as well. Is this kind of the is is this okay? Is this the right direction here? Yeah.
So 2 points. One is fear, and I'll come back to fear, right? The fear of the unknown. But coming to quarantines first, the way I see it, as the more as what we have understood of the disease, I think it may be time to do away with the quarantine, right? The point here being that anybody who has been, now it's two groups of people. Quarantine is usually those who are close contacts. So with regards to close contacts, if you're not symptomatic, you should be able to move around. If you're symptomatic, how I see, rather than quarantining, you should go and see a GP, a primary, at least a general practitioner or a primary care practitioner, who can then check you. If you want to do a self-test, you can do a self-test, right? But because you're symptomatic, I think you should go and see a primary care doctor, either in the clinic kesihatan or in the private clinic. That's for a close contact. With regards to a case, right? Cases are still being isolated, right, Joshua?
Yep.
That's not what we are discussing, right? We are discussing about the close contacts.
Yes.
So close
Close
contacts,
contact. Yep.
as we move forward, I think we don't need HSO. We shouldn't need HSO anymore. I think we should do away with the HSO. If you have COVID and if you self-test with COVID, you go and see a doctor and you get MC for 5 days or whatever, how many days you're getting currently. And if you're a close contact, go see a doctor, right? And basically get MC if you need it. Because if you're symptomatic, if you have a fever, even though you're COVID negative, I don't think so you should be walking around. I think you should be at home resting. And who better to assess you than a medical doctor, your primary care physician, your general practitioner, clinic kesihatan, so on and so forth. There is this point about fear, which I brought up. Now, as we transition, again, there's a lot of uncertainty. And as uncertainty, usually we react to uncertainty with anxiety. And typically fear also builds up because fear of the unknown, right? But what I would say is that many of the steps, many of the interventions that we're proposing or are being proposed are not being done in Malaysia for the first time. We're not doing this for the first time in the world. It's been practiced by other countries. It is the way we move forward, right? So with regards to COVID, the initial containment strategy was a failure. Many countries acknowledged it very fast and moved on. And we acknowledge we're in the mitigation stage. There's this talk about endemic phase, and we need someone to ring a bell and say, we're in endemic phase. Actually, it doesn't matter. We're just living with COVID at the moment, right? We have to learn how to live sustainably with COVID. We don't need WHO to ring a bell and tell us, we're in endemic, do so and so. I think as a nation, we have learned a lot. Our Ministry of Health is very, very capable. And from the amount we have learned with the trajectory of disease going, I think we can resume normalcy faster rather than later.